going to be a number of different things that we talk about today. Ultimately, it all gets back to this central purpose. What we do is to provide high quality emergency care to our patients when they need it most. So with that in mind, here's the outline for today. I've got a few brief news updates. We'll do a focused review on CPR. The bulk of the day is going to be spent on protocol updates. And then Julie Bolt from AMR is going to discuss peer support. Okay, so first, a few items of news. Legacy Salmon Creek is going to start using Pulsara for all pre-hospital notifications on January 15th. Obviously, the HERE system will still be available for backup, but the primary method is going to be using Pulsara. We have put together an education survey that was mentioned in the newsletter, and you can use the QR code here as well to access it. We want your feedback on the education that we provide, and we've gotten some great responses already. I really appreciate that. Finally, we are expecting to see a viral surge over the next couple of weeks. I'll go into a little bit more detail in the next couple of slides on what we know and what we expect to see. So this is emergency department volume at Legacy Salmon Creek versus the prior year. The patterns have been very similar at Peace Health. This graph was available to me, so I'm using it to illustrate it. It'll take a So I'm going to take a little bit of explaining. So the lighter color, what I'm highlighting here is the current volume rolling average of the 7 days. The darker line is what happened 1 year prior. And so if you look at November, in the previous year, November going into December, so November 2022 going into December 2022, we saw a really remarkable spike in ED volume. It was primarily driven by viral respiratory illnesses. It was a combination of COVID, flu, and RSV. And as you recall, it was around this time that we temporarily went into crisis standards of care, and we instituted a non-transport protocol for healthy adults with viral illness. My goal is to avoid that this year, and we'll talk about how we do that. The reason that I'm concerned is that we're seeing an increase now, and we typically in the 2 weeks following the holidays see an increase in viral illness. When we look at the EMS data, this is looking by week over the last 31 weeks or half a year. These are patients with chief complaints that fit with the viral syndrome: cough, fever, muscle aches. We're seeing an increase, particularly over the last 6 weeks, in the number of patients that we're transporting. And the patients that are, and this is by acuity, so the patients that are red acuity, obviously we're going to continue transporting. The patients that are yellow acuity, we're going to continue transporting. The patients that are green acuity, that's the one chance that we have to bend the curve in terms of the ED volume. And so we'll talk about what options we have to do that. And then finally, looking at the county data, this is looking at the week of December 24 to 30 of 2023. So this is the last one that's available. This is the percentage of emergency department visits that are related to COVID, influenza, or RSV. This is probably an underestimate since not all of them get tested. But again, we're seeing each go up, and what we see, as you've seen, COVID tends to be a little bit less seasonal, but then does have some spikes, and then influenza and RSV tend to be a little bit more seasonal. So we're going to go into the options we have to deal with that and how we're responding to that, but I wanted to give you that as background for what we're expecting to see over the next few weeks. Any questions about that? Okay. With that, we're going to shift gears and we're going to do a focused review on CPR and CPR science ahead of next month's skill sessions. So the 10 principles of high performance CPR. Number one, EMTs own CPR. And this is a case where, as in most things in EMS, foundation of everything we do is high quality BLS care. We minimize interruptions in CPR at all times, ensure proper depth of compressions, at least 2 inches for adults, ensure full chest recoil and decompression, ensure the proper chest compression rate. So we shoot for 100 to 120 per minute, 110 is ideal. We rotate compressors every 2 minutes with manual CPR. Hover the hands over the chest during the administration of the shock. Be ready to compress as soon as the patient is cleared. Our initial approach is IG-L airway with ongoing CPR, as long as you have good gas exchange. But if you are not getting adequate gas exchange, that is a time where we can consider intubation during CPR without interrupting. We place IV or IO with ongoing CPR, and we coordinate teamwork between EMTs and paramedics. Why is this important? So compression is when we increase the intrathoracic pressure, we eject the blood from the heart and the lungs. Good compression is how you get forward flow, you get perfusion to the tissues. With the decompression, with the recoil, you decrease the intrathoracic pressure. That allows refilling of the heart and the lungs, increases the vacuum, increases refilling, increases forward output. Why do we care so much about pauses? Pauses in CPR are directly correlated with the success of your resuscitation. The longer you pause, the less chance you're going to get someone back with a shock. So a 3-second pause, we're at around 100%. 10-second pause drops to 80%. 15-second pause, about 40%. And at a 20-second pause, you've lost almost all of that forward flow that you built up. So that's why those are the key focuses on CPR. And good CPR is the most important thing that we do to get cardiac arrest survival. So with that, we'll do a brief review of what we know so far about our data from 2023. So when we look at all comers cardiac arrest, the dark blue column are patients who have sustained ROSC. Obviously, for 2023, that's the only number we have so far. We're still compiling the hospital data, but that number looks to be about 41%, which is in line where we've been in recent years. These are still always relatively small numbers, so we can see bigger variations. In 2022, we had 32% survived to admit and 13% survived to hospital discharge. Again, that's all comers, all presenting rhythms. Most treatable form of cardiac arrest is obviously defibrillation, VFib and VTAC, and those are the Utstein survival. And so what I'm reporting for 2023 is only data on return of spontaneous circulation. However, almost all of these patients where we get return of spontaneous circulation, they are discharged from the hospital in good condition. So I suspect the final numbers are only going to be off by a few percentage points, if any. So in 2023, if no bystander CPR, 42% got ROSC. With bystander CPR, 51% got ROSC. So that represents a tremendous amount of hard work, dedication to improvement on everyone's part here. I'm grateful for that and proud to be working in a system like this. We're going to continue to look at every opportunity we can to improve that. Questions about CPR before we move on to the protocol updates? Okay. So we're going to discuss protocol updates, but first I'm going to talk a little bit about the philosophy of protocols. So in my ideal world, the protocol book would be one page and it would just say one thing. And so everything that we do in protocol, we are trying to get down to the simplest possible way to say this. We want to give you the tools to do the right thing. We want to make it as straightforward, as practical, and as realistic to what you do in the field as we possibly can. So with respect to protocol updates, 3 categories: treatment. They're going to be relatively minor changes in treatment protocols, just 2 things that we'll discuss. The bulk of the changes have to do with operations, particularly introducing the field referral to the nurse navigation line, which I think is going to be a really important tool for us and for our patients. And then the final just relates to a guideline on documentation in ESO. So we'll go through those each one at a time. So with respect to treatment, just 2 updates. We are adding in an epistaxis protocol with the goal of making sure that we're hitting the basics in terms of treating epistaxis. And then we're removing end-tidal CO2 from the death in the field protocol. And we'll talk about why we're doing that. So first, epistaxis. This is a very straightforward protocol. First move is direct pressure. When you have it available, you can then give oxymetazoline, which is a brand name Afrin, over-the-counter vasoconstrictor, 1 spray in each nair. Then apply direct pressure for 20 minutes without stopping. If the patient is still bleeding and you have it available to you for other reasons, because the primary reason we stop TXA is for trauma, you can give atomized TXA 0.5 milligrams via mucosal atomizer device. Why are we doing this? Like all bleeding, most important thing is good direct pressure. Why do we use Afrin? This is a case where what's bleeding is a mucosal bed. And so one of the most important things that we can do is to constrict the vessels. And that makes everything else that we do after more successful. Then we go back to direct pressure, which is the most effective way to control any bleeding. And then I did want to give those agencies that have long transport times and that have TXA available to them the option of using that. Does not require medical control at this point to do that. If you've done the first 3 steps, then you can move on to TXA. Any questions about epistaxis? Okay. With respect to end-tidal CO2 and cardiac arrest, there are 3 things that I want you to take away. Persistently low end-tidal CO2 corresponds to some patient that we're not going to resuscitate. You've been on these cases, some would likely in asystole, likely prolonged downtime. The end-tidal CO2 stays around 10, never changes. There's no surprise to us that those patients we're highly unlikely to resuscitate. If you are doing CPR and you get a sudden rise in end-tidal CO2, that is a sign that you likely have return of spontaneous circulation. What we have found, and this is kudos to the good both manual and mechanical CPR that's being done out there, we have been seeing persistently high end-tidal CO2. But if the rhythm is persistently asystole or PEA and the end-tidal CO2 stays really high, that does not correlate with survival. And so with respect to the death in the field protocol, we're focusing on the other items as determining when it's time to stop resuscitation. We're also giving feedback to the docs at medical control about this. Our goal is to not transport non-viable patients. And so we don't want there to be any confusion that a persistently high end-tidal CO2 in the absence of any other signs of life means that the patient is resuscitatable. Questions about that? Okay. Then we'll move on to operational updates. So there are three things that we're using in operational updates. There's just a small amount of text that we added regarding lights and sirens use. Most important thing that I'm going to do today is to talk about the reasoning behind that. We're going to talk about criteria for ALS evaluation, and then that's linked to field referral to the nurse navigation line. And then I just wanted to let you know that there are wording changes in the receiving hospital protocol. The reason for that is that we anticipate changes in hospital capability, but as of right now, there are no changes in destination policy. When these protocols go into effect, same patients would go to the same destinations as before. It's only a change in wording, but I just wanted to let you know so you weren't surprised by it. Okay, use of lights and sirens during transport. Now, I am going to try doing a poll here. We'll see how it works. If not, we'll just do things the old-fashioned way. So what I want you to think about is, on average, how much time does transporting with lights and sirens over transporting without lights and sirens save in Clark County? And let me see if I can make this live. Okay. See. Okay. So I'm going to give you the option. If you would like to, on your phone, you can go to pollev.com/MMACHT058, and I'll put that up on the screen. Um, it'll You'll have a chance to respond to this question. You can also text that MMACHT0058 to 22333. And I'll again put that up on the screen. Okay. So here's the text. You can also scan this QR code if you like. If you are responding by text, don't click on the link, just send the letter, what you think the answer is here. We'll give a few
Marlo,
minutes for people.
You might need to share your screen again real
Okay.
quick.
No, thank you for reminding me. Okay, Mark, you're seeing that now?
Yes, it's at the top. Yes.
Yeah.
Perfect.
Again, pollev.com/MMACHT058. You can text to 22333 and text MMACHT058, or you can scan the QR code. Okay, and we're seeing responses live. I'll give just another minute for people to answer. Okay, we'll go ahead and wrap it up. Looks like the consensus is more around 32 seconds. I'll be honest, that wasn't the answer that I was expecting. So the actual answer, based on data from April until December 2023, is 1 minute and 37 seconds on average. Okay. So thank you everyone for participating in that. So why are we talking about this? Well, what's the risk of using lights and sirens during transport? So this is data across the country, looking at 6 years, all of the ambulance transports in the country. If you look at the transport phase, so taking a patient back to the hospital with lights and sirens throughout transport, the risk of getting in a crash is 16.5 per 100,000 transports. If you're not using lights and sirens, the risk is 7 per 100,000 transports. And so if you turn on the lights and sirens, your odds ratio of crashing goes up by roughly 2.5. So again, numbers are low, but there is a significant risk, and there's an increased risk of crashing during transport. And because you have providers unsecured in the back, you have the patient, and because the speed is involved, these are often injury accidents. And in a small number of cases, they are even fatality accidents. When there are fatal ambulance crashes with a patient in the back, so this is again looking at over that same 6-year period, across the country, there were 173 fatal crashes, 199 fatalities, on average 28.4 people killed per year in the US related to an ambulance crash. And when someone is killed in an ambulance crash, half the time it's the occupant of another vehicle, wasn't even involved in the call. 6% of the time it's the driver. 34% it is someone who is in the back of the ambulance, and then 7.5% someone else who is outside the car, for example, a pedestrian. So that's these are small numbers, but when you think of all of the interventions that we do, this is the only intervention that we do that has the possibility of injuring someone who is not even involved with the call. So for that reason, several national bodies have made recommendations about the use of lights and sirens. So the National EMS Quality Alliance has a standard, safety-02. They measure the percentage of EMS transports originating from a 911 request during which lights and sirens were not used. NHTSA did a study on this and made recommendations. NHTSA is the National Highway Traffic Safety Administration. They recommend EMS agencies should consider a target lights and sirens transport rate of less than 5%. In other words, 95% of patients being transported without lights and sirens. The reasoning is that the small amount of time saved is likely to be of clinical value in only a small percentage of medical conditions. So how do we do here? So again, this is the last 180 days, looking by week. So we are moving in the right direction. And this is one of the key reasons that we moved to the acuity system as far as hospital notification. I never want, you know, the idea that you need to turn on your lights and sirens to get the hospital's attention, I think should be a thing of the past. I think that the hospitals owe it to respect your judgment as professionals, that if you think a patient needs to be seen, they should be seen. But there's much more that we're able to do in the back of the ambulance than we were able to do when we first started using lights and sirens. And so a number of times that there's something that the hospital has that you don't have in the back of the ambulance is very small. So so I'd like to continue to move this towards that 95% goal. Look at all the time over the last 6 months, we're at 85%. Most recently, we're at about 88%. We're definitely moving in the right direction. Now, there are a couple of ways to approach that, and I could say, well, you can only lose lights and sirens for this and for that. That is not the approach that we wanted to take, because we recognize that the use of lights and sirens is an operational consideration as much as it is a clinical consideration, and I wanted to respect your judgment to make operational calls in the moment. So I've highlighted the text that's been added to this protocol on transport mode. So lights and sirens may be used if the patient requires a time-sensitive treatment that is not available pre-hospital, and the expected decrease in transport time outweighs the risk of using lights and sirens. The rationale should be documented in the EHR. So, that could be, I had a hypotensive trauma patient that required rapid transport to a trauma center. Perfectly reasonable. I had a patient who was
Internet's back up.
I had a patient who was having a STEMI that required rapid transport to a PCI center. Those are reasons to use lights and sirens. There could also, and there could be an operational reason. The highway was completely backed up, and it would have been a significant delay in transport if we did not use our lights and sirens. All I'll ask is that you give it some thought and put that into it. That both, if something were to happen during the transport, you've documented your rationale for doing that, and for us trying to improve our system, we're understanding your thinking in the moment. I know that's a lot. Any questions about that? Okay. Move on. Okay. The next portion in protocol updates are to BLS response, alternate destinations, and field referral. So there are essentially two changes. We are changing the criteria for who requires ALS evaluation, and then we're adding field referral to the nurse navigation line. So why are we making these changes? Number one, so we'd had BLS 911 program in place since April of 2023. It's been a huge asset to the system. The people on those cars have been doing a fantastic job, and it's been a tremendous help. Right now, it's about 7% of 911 calls that are run by the BLS ambulance. When we look at the patients where BLS ambulance was dispatched and they ended up upgrading to ALS, 20% of those were for abnormal vital signs that were without symptoms. So when we look at how can we give the BLS car the chance to function to their full scope of practice while maintaining patient safety, we wanted to fine tune these criteria. The second thing is that we have a number, we have different options for things that we can do where we can send patients via BLS ambulance, we'll be able to use nurse navigation. We have psychiatric alternate destinations. We wanted to have the same basic criteria for each of those. Now, we'll go over the specific add-ons for each, but we didn't want you to have, a heart rate of 110 here and 120 here. We wanted it to be straightforward and to the point, simple to reference, and the same basic criteria for each of these protocols. So, criteria for ALS evaluation. So at a minimum, these are the things that require ALS evaluation. A complaint of chest pain, a complaint of shortness of breath, complaints that might suggest acute coronary syndrome. We decided to leave that in training rather than spell out all the specific things that could be that. We're going to trust the training that you have to identify that. If you think, I think this patient could probably use a 12-lead EKG, then that patient could use a 12-lead EKG. If a complaint is of new altered mental status or focal weakness, that requires ALS evaluation, and then impending or recent childbirth or care of a neonate, someone who is just born. Those are the subjective things. Objective findings: cool or clammy skin, a pulse less than 50 or greater than 110 at rest in adults, or for pediatrics, more than 10 beats per minute outside normal limits. For respiratory rate, a respiratory rate less than 10, greater than 25, shallow or labored breathing at rest, or more than 5 breaths per minute outside normal limits for pediatric patients. Blood pressure less than 100 systolic if symptomatic, or blood pressure outside of normal limits for pediatric patients. If there are new neurologic deficits on your exam, and then for alternate destinations, blood glucose of less than 70 or greater than 300. If other criteria, medication overdose or adverse reaction resulting in ALS symptoms requiring ALS intervention, or if you think the patient is likely to decompensate during the pre-hospital time. And then the final thing, crew judgment. So if you feel like this patient should be seen by a paramedic and you're an EMT, use that judgment, and we're going to respect that. Questions about these criteria? Okay, now we're going to go into the nurse navigation line. So, and this is something that has been available through CRESA since April. So people who call 911 with a low acuity complaint can get triaged to the nurse navigation line. Many of those cases are handled by the nurse navigation line. A small number of those get sent back and typically are transported or have a BLS ambulance dispatched. So what are the benefits of this? You have a nurse to help to get the patient to the right level of care. The nurses help to determine the appropriate level of care. And then there are options of care beyond the emergency department. So what are the options? So from nurse navigation line, some patients stay at home, just get a nurse consult on how to manage their illness. The nurse navigation line can set the patient up with a telemedicine visit that starts either right after the nurse navigation call or soon after the nurse navigation call. In that case, they're having a telemedicine visit with a licensed independent provider who can give prescriptions, who can advise them on their symptoms. And then another option that the nurse navigation line has is that they can refer the patient to urgent care, and they're able to sort through insurance issues and figure out what the right urgent care is for that patient. And then if the patient needs transport to urgent care, the nurse navigation line can help to arrange rideshare like Uber or Lyft to get the patient to urgent care. Now, Obviously, there are some limitations. We don't have 24-hour urgent care in this county right now, but those are the options that the nurse navigation line has, and that's why I think it's such an important tool. If the nurse navigation line talks to this patient and there's no other appropriate disposition, then a BLS ambulance to the emergency department, then they can refer back to BLS ambulance. For background, it takes the nurse navigation line about 10 minutes to go through that initial call and to set up one of these options. So what are the criteria? So first, you need to not have any of the criteria for ALS evaluation, nothing that you think is life or limb threatening. And then the patient needs to be willing. Only exception to this will be if we declare crisis standards of care. They need to have a normal level of consciousness. They need to not have cognitive impairment like dementia. They need to be cooperative. They need to be ambulatory, able to perform their activities of daily living. Age needs to be greater than 17, not under law enforcement custody, and a blood glucose of 70 to 300. So what do you do if you're on scene and you find a patient that's eligible? Okay. You explain to the patient that we have an option to help you. I think I can get you the right care in a really efficient way. And you're going to put the patient on the phone with nurse navigation. Whenever possible, or better to use the patient's phone so that they have that number and can contact them. There's one number for AMR to contact nurse navigation. There's another number for fire to contact nurse navigation. You're going to provide name, date of birth, gender, address, phone, chief complaint, your vital signs and your assessment, pertinent history or meds. And then the nurse may ask to speak to the patient directly, or that conversation can happen on a speakerphone. Like I said, it's on average about 10 minutes to navigate through that. You might have a disagreement. We're rolling this procedure out. We might ask, you can, if there's information that nurse navigation doesn't have, you can provide that information. But if nurse navigation is recommending transport, I ask is, let's not have an argument around that. Let's honor that request. The patient might refuse to speak with the nurse, refuse the triage. Unless we're in crisis standards of care, we're going to honor that. Encourage the patient to speak with nurse navigation line and say, I think we can get you the care you need a lot more efficiently this way. But if the patient insists on going to the emergency department outside of crisis standards of care, we're going to honor that. How do you document this? So in ESO, your unit disposition is going to be patient contact made. Patient evaluation and care is patient evaluated, care provided, meaning that you assess them and refer them to an appropriate resource. The crew disposition is going to be initiated, continued primary care. Transport disposition is no transport. And the reason for refusal release is that the patient is released following protocol guidelines. We do not require refusal signature for this. That is because when a patient voluntarily contacts the nurse navigation line, we've got documentation of that call. The nurse navigation line does callbacks the next day for follow-up to make sure that things are on track. So this does not require a refusal signature. Your documentation should include the patient demographics, full assessment, 2 set of vitals, and a detailed narrative, including the nurse's name. Any questions about nurse navigation? Okay. Finally, we still have the psychiatric alternate destinations. There's no change in these other than we're just saying, okay, first ALS criteria, did this patient meet ALS criteria? Get them evaluated by ALS. Non-life threatening, you have the option of nurse navigation. And then if you have a psychiatric chief complaint, then you have age greater than 17, less than 55, not hypothermic or febrile, not new onset mental illness, not an overdose, not known pregnancy, not evidence of a medical or traumatic problem that's acute, not with current use of anticoagulants, and no loss of consciousness or seizure in the last 24 hours. If there's a disagreement amongst the providers, you can transport to an ED or consult medical control. And no change in that. That just flows from the criteria that we use for the other dispositions. And then finally, I mentioned some change in the wording on the receiving hospital protocol, and I'll show you that now. So what we did is we just named the specific presentations that need specific hospital resources. So if you have a red or yellow acuity trauma patient, or even if they don't fit all the criteria, but you think they're probably going to need a trauma center, go to PCL Southwest unless the patient meets the criteria in receiving hospital diversion. The most important one there are trauma alerts less than 15 years. Those are the ones that, unless you acutely need airway or other issues, you go across the river with those. Number two, STEMI, cardiac arrest with return to spontaneous circulation, transport to a facility of 24/7 PCI. As of right now, PCL Southwest is the only facility in the county that has that. We anticipate Legacy to have that capability in April of this year, but we will notify you when that is up and operational. Severe GI bleed, suspected esophageal varices, transport to a facility with 24/7 IR. As of right now, eSouth is the only facility in the county with that capability. We anticipate Legacy to have that, but again, so roughly in April, and we'll notify you when that happens. And then stroke patients, the patients that require the comprehensive stroke center at Peace Health Southwest are LAMS 4 or 5, symptoms more than 3 hours, less than 24 hours, patient comatose, profound paralysis or aphasia, suspected intracranial hemorrhage, age greater than 80. Patients can go to the closest stroke center if symptoms are 3 hours and less, and they don't have any of those above criteria. So there's a slight change in wording. There's no change in the destination protocol.
Dr. Gadbois has a question.
Yes, go ahead.
Thank you for pointing out the transport protocols. I would say that, just for clarification for everybody on the call, is that if the patient is in cardiac arrest, that they'd go to the closest facility.
You meaning like cardiac arrest without return to spontaneous circulation?
Correct.
Yeah, right. But if you have ROSC, these ROSC from a cardiac cause, the patients that we suspect are going to need PCI, then you want to go to a PCI capable hospital. Okay. Any other questions about receiving hospital protocol?
No, just sort of my avocation on this is that I really don't want any. I really would think we would want to reduce the number of cardiac arrests without ROSC that are being transported.
Agree completely, and that's part of the focus of the the end-tidal CO2, removing the end-tidal CO2 from the protocol, and then other than that, we're going to address that with education with the doctors, doing everything that we can to give a report to them that makes it clear to them that not resuscitatable patients we are not intending to transport. That's something that's very front of mind, for all the reasons that we talked about earlier. That's not a good use of our resources.
Correct.
Absolutely, and I think I'm referencing the times that we've had pediatric arrests and bypassed other hospitals.
No, correct. Often docs can be more nervous about terminating resuscitation in a pediatric arrest, but there are, if you have a pediatric patient in cardiac arrest, the closest hospital is the best place to go.
Correct. I mean, very simply, it's because of the mechanism of the arrest. A a pediatric arrest should not be transported past the closest hospital because the chance of it being due to a cardiac issue is minuscule. This is respiratory, it's another problem, respiratory sepsis, whatever, SIDS. And if you're actually going to transport that child, they should go to the closest hospital where they have competent emergency department.
Agreed.
And
Agreed.
not,
Thank you.
and not across state lines to the pediatric hospitals.
No, I agree completely. No, thank you both. Okay. Final thing that we are adding to the protocol is a documentation guideline. Why are we doing this? So within the last year, we now have everyone in the county on the same charting platform. So one, we want to enable you to do efficient, high quality documentation. That means eliminating as many things that are unnecessary so we can really focus on what's necessary. And then we really want to be able to get consistent data that we can use to improve quality. To be able to do that, we need to, we have the same system. We need to use it in the same way to be able to get consistent, high quality data. I won't go through every single item in the documentation protocol today, but I'm going to hit the key points there. So key points in the documentation protocol. Where possible, we want you to use fields. Those tend to be much easier to search, but then we want you to go into free text for what can't be captured in fields, whether that's some unique finding on assessment or something that you saw on the scene. Use free text for what you can't put in a field. For each chief complaint, there are generally 1 to 2 organ systems that need a detailed exam. So for example, if you have a patient with shortness of breath, you need a detailed cardiac and lung exam. If you have a patient whose chief complaint is headache, then you want to document what their neck feels like, look for sign of meningitis, and then you want to document their neurologic exam. And so my goal in this is that I want you to focus the detail where it really matters for that presentation. And then, for someone with, with the chief complaint of left arm weakness, I'm less concerned about the belly exam. Save your time there, put the detail where it's relevant for the chief complaint. I want you to put your thought process in the narrative. I worked 2 shifts over the weekend. I know I messed something up. I don't know what yet, but what I did try to do to the best of my ability is to document why I did what I did, what I was thinking in the moment. And so that's the key thing that we're going to be looking for in your narrative. And then finally, with respect to primary impression, worst first. So if someone is complaining of anxiety and chest pain, then the primary impression should be chest pain. We always, with respect to the impression, we always want to think of the worst possible cause of the patient's symptoms. It demonstrates that we were cautious, that we used a thought process, and that we assumed the worst possible explanation for the patient's symptoms. Then in the documentation guideline, we've got a few specific points that are relevant for specific types of calls. For example, trauma, if there was a delay in scene time, document that. There are a number of things for cardiac arrest, and those are targeted to giving you the information you need to get credit for hitting our key performance indicators. Questions about the documentation guide? Okay. Timing with these protocols. So it would be my preference to wait until everyone has had a month plus to complete this training and then to go live with the protocols. Unfortunately, because and I really hope I'm wrong about this, but because we anticipate this viral surge coming over the next few weeks, I want to have the field referral to nurse navigation available to you as soon as possible. So on January 15th, if you have completed the training, then you can go ahead and use field referral to nurse navigation. Encourage your peers to complete the training as soon as possible. Obviously, it's going to be much easier if everyone on the scene has completed the same training. But because of the situation that we're in, I wanted to make that available sooner. The remainder of the protocols will go live on February 15th. And so with that, I'll go into the take-home points and wrap up. So number one, we expect a viral surge mid to late January. With respect to treatment protocols, we added epistaxis. We removed end-tidal CO2 from the death in the field protocol. With operations, we ask that you document your rationale for using lights and sirens. We've changed the criteria for ALS evaluation. We've added field referral to the nurse navigation line. With respect to documentation, we've added a documentation guideline. With that, here is the link to give feedback. You can use your QR code to scan this, and I will paste it in the chat as well. I appreciate your feedback. And then with that, I'm going to turn it over to Julie Bolt.
Okay, can you hear me?
Yes, we can. Thank you.
Okay. All right. And can you see the PowerPoint that I am attempting to share?
Yes,
Okay.
just went away.
It just went away. Okay, let me try this again. Okay, now can you see it?
Yes.
Okay. All right. So the MPD's office was very generous in letting us look at our mental health. A lot of our training goes to like protocols and how we respond, but when it comes to our mental health, we deal with that from the time we wake up in the morning to the time we go to bed at night, not only at work, but at home. And we are trained a lot more in how to deal with physical injuries than with stress injuries, especially those of us who went through school several years ago. So we want to discuss how to deal with those stress injuries. When you're thinking about your mental health, I want you to think of it kind of the same way you think about your like when you work out. So so we're going to just kind of go over a few things here. So when you stress your muscles, sometimes you need to stress your muscles in order to build them, right? Same thing with mental health is stress isn't necessarily a bad thing, but it's something we all go through and we need to figure out how to deal with that. There are two hormones that are released during stress, and one of them we're all familiar with, that adrenaline response. A lot of us seek that, right? The other one is cortisol. So cortisol is a lot like prednisone. It helps keep our airways open when we're in stressful situations, and helps us maintain that kind of adrenaline response. But like prednisone, it can cause some long-term effects. So, Dr. Mock, can you tell us what long-term prednisone patients look like and some of the problems they have?
Yes, I mean, they tend to have this Cushing-like appearance, meaning that like the swollen faces, they retain water, they're immunosuppressed, and so prone to frequent infections. They have problems with the connective tissue. It's just like long-term steroids are really hard on your health.
Okay, so the two biggest killers of first responders are suicide and cardiac arrest or heart disease. So when we look at long-term prednisone patients, I know one thing that I've noticed is when you go to start an IV, their veins just blow. So that is true with our vasculature after we have had cortisol dump and dump and dump over years of working in EMS. So that is some of the issues with the heart disease that we face. So there's two areas of your brain that that we work off of when we're trying to when we're in stressful situations. So one of those is the limbic system. It kind of goes from your brain stem to the limbic system, and then you hit that fight or flight mode. Hopefully what we're working on when we're in PSEP is that we're working out of our prefrontal cortex. And your prefrontal cortex is where you do all your thought process and try to figure out, like, this is a complicated medical patient. So what meds are they on? How does that affect their anatomy? And how does that affect the meds that I'm giving? The problem is you can't work out of your prefrontal cortex and your limbic system at the same time. So if you're in fight or flight mode, it's very difficult to then work on your prefrontal cortex and be able to think through those things. That's why like the commander in an ICS scene stays way back so he or she can get a bigger picture of what is going on. Some ways, like slowing down your breathing and just getting a bigger picture, will help you transition from that limbic system to your prefrontal cortex. I want to look at some of our sources of stress. So I've got Nate on here. Can you let us know what some kind of administrative stress, what we face as first responders?
Can you hear me?
Can you?
Yes.
Yes, I can.
Okay. So some of the biggest things that we face as first responders is we see horrible, awful things, and it's hard to process those things sometimes.
Right. How does like admin, some of the things that admin says, just the extra stress that administration can put on us? What are some of those things for the different agencies?
So administrative stress is things around the station, depending on what agency you're in.
Okay. And how about like stress at home? How does our job affect our home life?
Sorry, I'm having technical issues.
That's okay.
So in seeing the awful things that we do at work, it's hard to take those things that we've seen and then go home and have a normal life. It's hard to go back and forth, especially if you're underslept, especially if you've seen just awful things. So that can be stressful. So like the biggest, the most important thing that we can do is make sure that we're talking to people about what we see,
Okay.
which helps that transition.
Right. And I've got Josh Robertson is up with North Country, and he's on our peer support team. Josh, what have you noticed over the last few years about the increasing stress just working on the streets and working with public?
Well, throughout COVID, we had a significant increase in, I think, stress in our job in general. And I think a lot of that has been carried through to seeing in with our patients. We've had a increase in mental health response significantly. And then as the rebound from COVID and the struggling in all the departments to hire enough medics to cover it, we've been running a higher call volume as a result. And you see a lot more stress, I think, in the system, the field for paramedics who are and crews that are just running a much higher call volume, and that's going to wear you out if you're on 12s or 24s. You just can't maintain that level.
Right. Right. Another thing that I've noticed is that there's cameras everywhere, and that didn't used to happen. And that can be an added, not only that we're constantly being videoed, but also that there isn't the appreciation for EMS that there used to be. So we're no longer the heroes that we used to be. That people are much less trusting of us. So that is some added stress there. So there's two different kinds of stress. There's acute stress versus chronic stress. And acute stress is fairly easy to, well, I wouldn't say easy to get out of, but sometimes we can get out of it a lot quicker. It's that critical call we ran. It's your car broke down, those things maybe within days you can get out of, versus the chronic stress, like I'm not getting along with my partner, my captain is driving me crazy, the patient that calls again and again and again, or that the system is just broken. Those kind of stresses tend to wear on us a lot longer and are the least noticed. Like usually what we hear is, oh, people have PTSD from this one call, but usually it's not one single traumatic call. It's usually multiple calls after multiple calls. And that can add up. So there's also emotional triggers that goes along with that. If you have a sick family member or or you're dealing with issues at home, and then you run a call on someone your child's age, or you're dealing with an parent that's getting older and you're getting ready to put them on hospice, and then you run someone about that age who is in cardiac arrest. Those are all triggers. Maybe you ran a similar call. So usually what I'm finding when I talk to crews, it's not the call, it's how the call affected the way their home life is. One thing that was developed by the military, this is the Homeland Security's version of the stress continuum. It was originally developed by the military, and it kind of goes through, like, if you're green, you are good to go. You have a lot of support. You know how to take care of yourself. And then you go down to yellow, and that's when you're starting to get tired. Maybe there's been a serious, maybe there's something going on at home, or maybe you've run a few critical calls, it's easy to slip from green to yellow to orange. And some of us just sit in red after years of in EMS, right? That maybe you're using alcohol to go to sleep, or maybe you're not sleeping, or in EMS, there's a high incidence of suicide. So maybe you're kind of thinking through that. So it used to be that peer support and counselors in EMS only dealt with patients in red, because that was the only people who were referred to them. Fortunately, we're moving up that stress continuum a little bit, and we would like to stay in green to yellow. It's not possible in EMS to always be in green, because we do run those critical calls. I don't think anyone, whether they're in EMS or not, stays in green all the time. Life just happens, but it is, how are we going to deal with that? So another thing that I want to bring up is that substance misuse is very typical in stress injuries. The problem is it's not a great coping mechanism, and people with PTSD are much more likely to become addicted or misuse substances. So how do we deal with all this? There's this thing called neuroplasticity. It means that we can, like we build our muscles, we can build our resiliency. So what is resiliency? It is our ability to survive, adapt, and grow through all the things that we see and the stresses of our job and home life. So part of it is that we want to change our culture, that it's okay to talk about what's going on, and that we really need to find good coping mechanisms for this. Part of that is that every single one of our departments has a peer support team, and you can go to that peer support team and get some help or get referrals. If you are not comfortable going to your own peer support team because you're concerned that the word's going to get out, which, by the way, we are all legally bound by confidentiality. But if you are concerned about going to your own peer support team, we now have a Clark County regional team that has a list of peer supporters from all the different agencies, and we have all been trained with the same ICISF training, and we're all held to that legal confidentiality. So another good way is social support. The more as first responders, we're really good at isolating when things start to bother us. So whether it is social support in a group outside of EMS, which I highly recommend you keep your social support outside of EMS, because sometimes you just see all the world as only elderly and only alcoholics, and is there anyone else in our community? So it's nice to have that support outside of EMS, but sometimes only first responders can understand what we go through. And so it is really good to have that social support inside EMS also. So yeah, go ahead.
That's a huge one. You need to have people, friends that you can talk to that aren't first responders. It just gives you a different perspective. It's a little bit more balanced when you're constantly talking about the horrible things you see or the stupid things that admin does. It just kind of it just weighs on you. So just having people that aren't in that realm is huge.
Right, right. So sometimes we get a very narrow view of the world, and it's a lot of effort to keep those relationships outside of EMS, especially when you're working 12s or 24s or nights, because you're the only one that sleeps all day and is awake at night, but it's really worth that effort. So I just want to remind everyone that you are in charge of your mental health, and there is huge support if you need some extra assistance, whether it's from peers or counselors or chaplains, but your coworkers don't know if they don't know. So find someone you can trust, and go ahead and just get that help that you need. And that's everything I got.
Any questions for Julie? Well, thank you, Julie. That was very, very helpful. Just a quick reminder, protocol updates will be out here within the next week. Might be 2 weeks for the app to update, but be expecting of that as we move forward. If any of you have any questions, please reach out to any of us in the MPD's office or your training and clinical department. And with that, I guess, Happy New Year. Thanks for coming.
Thank you.
Thank you. Have a good day. Good job, Julie.